I'm going to read a condensed snippet from a chapter of a book called The Barbell Prescription by Dr. Jonathan Sullivan. This book promotes the use of barbells for healthy aging. In this chapter, Dr. Sullivan paints a picture of a type of patient that I'm unfortunately familiar with, and is a sobering reminder of what happens when you stop taking responsibility for your health. I've extracted, condensed, paraphrased, and rearranged parts of this chapter to allow it to flow better. This is quite long, but I think it's important to listen to it in its entirety. It explains why I feel so strongly about what I do. Here goes. Phil displays a common phenotype. Somewhere along the line, he took up smoking, drinking, and lots of quality time with his big screen TV. He's planning on watching the entire third season of Battlestar Galactica this weekend for the fourth time. To keep his edge, he drinks lots of Pepsi and keeps scrupulously up to date on his Netflix queue. He's a fiend for Domino's Pizza and Doritos. He likes to cook with frozen ingredients and a microwave. His body fat is through the roof. He's about 48% fat by weight, and he tips the scale at 283. He doesn't like doctors, although he's known to make frequent trips to the ER for chest pain, fatigue, sore joints, or a skin infection. He hasn't had a real erection since the start of the Obama administration. He has type 2 diabetes, arthritis, messed up serum lipids, and high blood pressure. He doesn't know it yet, but he also has a ticking time bomb in his left anterior descending coronary artery. 3 years from now, this lesion will clamp off the blood flow to Phil's left ventricle in the middle of a Die Hard movie marathon. He will spend 6 painful weeks in the hospital after his heart attack, battling cardiogenic shock, pneumonia, a nasty bedsore, sepsis, and all manner of wickedly invasive and painful medical interventions. His great final adventure comes to an end on his 43rd hospital day, when a thrombus breaks loose from the deep veins in his fat-laden, chronically underused legs, lodges in his main pulmonary artery, and mercifully dispatches him from his miserable existence at the age of 58. How did this happen? Phil's sedentary lifestyle led to decreased muscle mass. His declining muscle mass created a parallel decline in muscle glucose utilization and muscle insulin signaling. The progression of Phil's sedentary lifestyle to metabolic syndrome is a perfect scenario for the loss of even more muscle mass, and further decreases in total body insulin sensitivity. Activity becomes more tiring and more uncomfortable. The organism becomes more inactive, and so on. This vicious cycle affects many tissues, not just muscle. Tendons and ligaments lose their stiffness, becoming weaker and more susceptible to strain and injury. Cartilage, a tissue notorious for slow growth and repair, grows thinner and more frail. Even nerve tissue undergoes a progressive deterioration in aging, and declines in growth factor stimulation and insulin sensitivity are at least partly responsible for brain atrophy and dementia. Hyperglycemia eventually slides into full-blown diabetes, and Phil needs oral hypoglycemic medications like metformin or glyburide to control his blood sugar. These medications are effective for a while, but they don't get at the real root of Phil's disease, and they have significant, occasionally fatal, side effects. Eventually, Phil will get his first prescription for insulin, syringes, and needles, and the fun will really begin. Phil's elevated blood pressure progresses to severe hypertension, and his doctors have him on no less than 3 blood pressure medications. These drugs are now absolutely necessary, but they make him dizzy sometimes, which further potentiates his sedentary proclivities. Phil's sarcopenia continues unabated. His body's muscle mass, which should be a vast landscape of insulin receptors and a major consumer of food energy, is becoming a wasteland of weak, stringy, insulin-resistant, well-marbled, dysfunctional meat. Phil's exercise capacity has gone from poor to pathetic, and his opportunity to turn things around diminishes with every gram of muscle tissue lost. Since Phil never lifts anything heavier than deep dish pizza, His skeleton doesn't have much to do, and his bone density is dropping fast. Osteopenia is the ever-present sidekick of sarcopenia. Phil is progressing from weakness to full-blown frailty. Illnesses and injuries that would merely be troublesome and painful for a healthy person would shatter him. Phil is easy to break. Systemic inflammation propels Phil into a twilight realm of chronic pain. His joints are creaky and achy. What's left of his muscle mass is sore. His tendons and ligaments are floppy and weak. They injure easily and heal slowly. Phil has knee pain, back pain, neck pain, shoulder pain, headaches, delicate skin, and a chronically upset tummy. Phil's dyslipidemia prompts his doctors to start him on statins to lower his cholesterol. He turns out to be one of those individuals in whom statins lead to muscle pain, making it even more unlikely that he will begin an exercise program anytime before the rapture. This pharmaceutical stew seems to help Phil limp from one day to the next. For the most part, Phil needs these medications now to stay alive and cope with what's left of his existence. But none of these medicines do anything to correct the underlying pathologies they treat. His kidneys and retinas are showing signs of damage. Arteries in his heart and brain are riddled with degenerative plaques. He hurts all the time. His strength, exercise tolerance, and mobility are in the toilet, along with his quality of life. He hasn't been laid in years and couldn't get it up even if the opportunity miraculously presented itself. Phil never has a chance to survive his heart attack because he has what doctors in polite company call inadequate physiologic reserve. All this was completely preventable. Anyone who holds that this doesn't come squarely down to behavior is on the losing side of the argument. Phil treated his body like a rental and never took ownership of his own flesh. He abdicated his responsibility for nature's greatest gift to him, the miraculous machine of muscle, bone, blood, and brain bestowed upon him at his birth. He abandoned his body, and it abandoned him. Phil's self-destruction wasn't a nice, neat, linear process. It was rather like a slow-motion train wreck. Phil's death was the culmination of a long cascade of interconnected, interdependent processes. It began insidiously with a little weight gain, a little loss of lean mass, a little decline in exercise capacity, a little elevation in blood sugar and blood pressure. At this stage, Phil looked and felt pretty much the same. He had to buy bigger trousers, and his energy wasn't what it once was, but no big deal. Within a decade, these processes had progressed to clinically recognizable disease and moderate functional debility. Within 2 decades, they had blossomed into full-blown diabetes, severe hypertension, morbid obesity, impotence, chronic pain, disability, frailty, polypharmacy, a miserable quality of life, and the coronary artery disease that would ultimately do him in. Phil's story is an extreme but common one. Depending on multiple factors, including genetics, many people bear the burden of metabolic syndrome and its evil gifts better and longer than Phil. Some will live to be 60 or 70. In other words, they get to suffer longer than Phil did. Many others age without all this extreme pathology, but without intervention, they still face a future of sarcopenia, osteopenia, weakness, and frailty. In other words, as they age, their muscles will atrophy, their bones will become brittle, they will grow progressively weaker, and their resistance to trauma, disease, and even stresses of everyday life will put them at an ever-increasing risk for morbidity and loss of independence. Sick aging phenotypes appear to be self-reinforcing. Weakness and decline driving more weakness and decline, circling the drain faster and faster until there's nothing left. The complexity and synergy of the pathologic processes underlying the sick aging phenotype forces us to ask, at what point is it too late to stop the train from leaving its tracks?